and D to 100%. We'll give you a minute there. I minimized that screen, so you have to let me know when folks are ready to move to the next one.
And just be sure to scroll because there's 3 questions all in the same quiz or
Okay.
poll.
So are we ready? Are we ready to move on to the next one?
Not yet. We have
Okay.
3.
You let me know and we'll do it.
I'll let you know. Yeah, give it a minute or 2. When we get closer to 20 people have completing the poll, I'll let you know. We're up to 6 now. Okay, I'll stop it at halfway. We got unless you just want me to end it now. We've got 12 of 26 with a complete answer. Now we're at 50%.
All right, should we go to the next one?
Sure.
That's good.
Oh, well, yeah, go ahead because all 3 questions are on the same. So you should go to the next one. I'll keep it open.
So just give you a quick hint if you're a Star Wars fan. There's a line in Rogue One where the plucky robot asks the guy in charge of the mission what the chances are he's going to get shot with a gun that a girl's brought. And he tells him that the chances are high, very high. And so that's going to be kind of the theme for a lot of the things we talk about tonight is the chances of badness is high, very high. So second question. We have a pregnant woman who tests positive for syphilis during pregnancy at 24 weeks gestation. She was negative for syphilis 6 months ago, and she has a history of anaphylaxis to penicillin. So you decide A, defer treatment until after she delivers the baby, B, treat with doxycycline, C, treat with ceftriaxone, D, desensitize and treat with penicillin, or E, treat with azithromycin. So have you vote on this one here?
You can probably move to number 3 now.
All right. And question 3 is, what is the major driver of congenital syphilis, the catastrophe that we have in the US and Arizona? Is it A, inadequate screening recommendations, B, resistance to penicillin, C, inability to quickly test and treat pregnant persons, or D, reinfection after adequate treatment?
All right. I'm going to go ahead and close the poll.
All right, we'll move on. We'll definitely cover these things here. And so now I wanted to kind of move forward and give you, again, kind of a range of things that we tend to see as far as congenital infection. And a lot of this talk is going to be focused on congenital infection because I'm a pediatric infectious disease doc, but we'll also talk a little bit about adult disease as well and diagnosis and treatment. This is kind of the worst case scenario. This is a case that our pathologist here shared with me that they had recently. But basically, a 28-year-old gal came at 25 weeks gestation, and she had fever and chills and had vaginal bleeding. And unfortunately, she had intrauterine fetal demise at that time. She hadn't had any prenatal care, and she had a syphilis test that was positive. And so after they delivered the fetus, they did a postmortem. And so they saw generalized desquamation of the skin. They saw organ autolysis, and then they saw basically spirochetes everywhere. And you can see here in this path slide, this little spirochete that's there in the brain tissue. And all this little pink all over the place is this organism, Treponema pallidum, in the pancreas. And so you can see it, really caused a lot of trouble and unfortunately killed this baby. And this is, what we see as a worst case scenario as far as congenital infection goes. And there's a 40% mortality with infant infection and with congenital infection. So it's a big deal. The next case is another one that's along this spectrum. that a pregnant woman showed up at 28 weeks gestation and she hadn't had any prenatal care. She was using drugs and she had these genital lesions. And you can see these are classic condyloma lata, which is secondary syphilis. And so she had active syphilis at the time of presentation, and she shortly delivered. And the baby had, very symptomatic disease. And so you can see had this peeling of the skin, which, you certainly can see a little bit of peeling in post-term and term babies, but you don't usually see it in preterm babies. And so this was definitely pathologic. Had intrauterine growth restriction, ended up having hepatosplenomegaly, had CNS disease, had osteitis, and you can kind of see in this x-ray this lucency here and this ratty edges of the bone. And so this baby really had multi-organ involvement, but fortunately was treated and survived. And then kind of the last end of the spectrum is this patient. This is a 3-week-old that showed up in the ER and had a little bit of kind of this waxy kind of lesion on the scalp that thought maybe it was cradle cap, but showed up at the time in the ER with some elevated LFTs and some fever, and ended up testing positive for influenza. Looked okay, so they sent the baby home. But then weeks later, you ended up having this big, nasty kind of ulcerative lesion that went all the way down to the skull. And as they got more information, it turned out that this mom had a history of a negative syphilis test at the beginning of pregnancy, but was never tested again during pregnancy. And then again, this happened weeks after delivery. So a mom ended up having a rash herself on her hands at the time of this happening to baby, as you can see. And then they tested both mom and baby, and both of them tested positive. And so you can see baby can look completely asymptomatic at delivery, but can go on to have symptoms and can be serious. So the good news is they both got tested, or they both got treated, and they both did well. So that's kind of the spectrum that we can see with congenital infection in these infants. Just a quick history of syphilis. I think it's pretty interesting. We think that the academic community that does research in this, not me, but that basically thinks that syphilis probably came from the New World and then came over to the Old World right after Columbus got back from his first visit to the Isle of Hispaniola. And that's when it shows up in the port cities in Europe, and then it kind of spreads throughout Europe. The interesting thing is that secondary syphilis, which nowadays can cause a whole host of symptoms, but is often mild, back then when it first showed up and became a global pandemic, was really at a high mortality rate. And they did all kinds of things to try to combat it. And there were lots of different treatments. And in many cases, the treatment was worse than the disease. And so this is an old picture that someone had made, that they had this dome that you would go in, and they would add in this kind of aerosolized mercury that you could breathe in. And that could kill syphilis, but unfortunately could kill the patient a lot of the time too. And if they survived, they could have renal failure, have their teeth fall out, have all kinds of problems. A guy in the 1920s got the Nobel Prize for giving people malaria because they found that the fevers that were caused by malaria could bring people out of their catatonic state when they had tertiary syphilis. And so that was a way to combat that in a situation where they had no other good treatment. Unfortunately, there was a 20% mortality rate with that treatment. And then along came the arsenicals as well. And so you had things like salvarsan that could treat syphilis, but had a really narrow therapeutic window. And so it was really difficult to treat syphilis in the early days when people were trying to figure out what to do. And there are all kinds of, snake oil remedies and that sort of thing that people would sell. But along comes penicillin, and it really revolutionized the treatment of syphilis. And people really thought that here was now the end of the era of syphilis, and we wouldn't have to deal with it anymore. But unfortunately, as we all are probably recognizing now, there's still a lot of syphilis running around. And it's not because there is antibiotic resistance. It's for a whole host of other reasons that we'll talk about here in a minute. So when we look at it, it's a spirochete, this, squiggly bacterium. It's really contagious. A single exposure, active exposure, has a 30% transmission rate, and it's a bacteria that can really penetrate mucous membrane. So it's easy to get into the person that has been exposed. This is a old outbreak investigation that happened in the early 1900s. It was published in the 1960s, but it basically shows a young man who had syphilis, who then came and spent time with sex workers and infected them, who then infected their clients, who then took it home and then gave it to their children. And so you can see how it's really easy for something to really quickly spread through a community and have widespread infection. When we look at moms giving it to babies when they get infected when they're pregnant, there's a really high rate, but again, it depends on what the timing is of the infection in mom as far as what the chances of transmitting the baby. But again, it's really high. And so if you have early disease in mom during pregnancy, there's a 60 to 100% chance of transmitting to baby. And then if you're early latent, and early latent is infection within the first year, then that has a 40% transmission rate. And if you're late latent, so your infection was more than a year ago, then it's lower at 8% or so. But again, it's hard to tell, and it doesn't work the same way for everybody. This is an example of another situation that was published in this book in 1964 that showed a mother who was infected. For some reason, dad never got the infection, but over the years, she transmitted it to 6 of her 7 children. And so even though there was a low risk of transmission, she certainly transmitted it to a lot of her family members, and with all the associated problems that went with it. This is an interesting scenario. Usually, again, you would think that, dad would bring it to mom, mom would give it to baby. But what happened here was a more roundabout way. What happened was that grandfather gave it to grandmother, and grandmother had her own baby that she was breastfeeding at the time. Well, daughter-in-law also had a baby that she was breastfeeding, and grandmother was helping breastfeed the grandchild. And what happened is that the grandmother transmitted syphilis through the breast milk into the baby. The baby got a chancre in the mouth, and then baby, who now had infection on that mucous membrane, now was breastfeeding on mom's breast and gave mom a chancre on her breast. And then she became systemically infected and then gave it to her husband. And so you can have that close mucous membrane contact with people and get infected. So it's not always sexual transmission, and it's not always maternal to child, but that's usually what happens. So when we look at the risk factors, it's the things you would expect, right? Multiple sex partners, multiple risks for exposure. But the problem is that when they've looked at mothers who have delivered babies who are congenitally infected, 70% of those women only had one partner during that last 12 months. And so that means that either the other partner was not monogamous, or the mother had had it for more than a year and had transmitted to baby. But the moral of that story is you can't look at someone and say, you're in a monogamous relationship, you have no risk factors for syphilis. And that's one of the reasons why we need to be really vigilant on screening everybody, no matter what their risk factors. And then the other things here in the list, right? Drug use, history of other STIs, poverty, high prevalence of syphilis in the community. Again, things you would expect, because these things limit people's access to care and their ability to get tested, treated. When we look at how syphilis shows up in people, we tend to look at it from an adult type disease, so non-congenital versus congenital infection. And there's different stages that we talk about in the adult type disease and also in congenital disease. And we'll talk about that here in just a second. So the primary stage is the earliest stage. And basically, this is where you get mucous membrane lesion at the site of where the spirochete basically had contact and invaded. And so it starts out as a papule, and you get this erosive lesion, which is the chancre. And it's this well-demarcated lesion that's painless. And so this lesion can be in lots of different places because it depends on where that exposure was. But since it's painless, it may go unnoticed. It's highly contagious if you have direct contact, but you may have it in tissues that people aren't looking for. And so you can imagine that someone would have one of these lesions that would come and go, and they wouldn't know, so they wouldn't know to get tested, or they wouldn't know to mention it to anybody that would say, we should worry about this. This heals over the course of weeks and then goes away. And then you enter into the secondary stage, and that happens weeks after that primary lesion. And this is where people can be fairly symptomatic, and this is where it can kind of go anywhere and do kind of anything. And that's why people call it the great imitator, because there's all kinds of people that had, weird presentations that they thought was something else like lupus or what have you, and oops, it was actually syphilis after all. And that's why you see syphilis on the differential diagnosis for a lot of things, that if they come in with certain signs and symptoms, you should be testing them for syphilis in the right situation. But again, it can go kind of to any organ and system and do any kind of thing. And you may be fairly symptomatic with fevers and adenopathy. You may be pretty asymptomatic. You may have rashes. You may have all kinds of different things. And again, it's hard to tell for sure that that's what it is unless you're really thinking about syphilis and testing for it. And then you can kind of go to quiescent and then relapse over and over as time goes on. And that's probably what was happening to that mother who gave it to her six out of 7 kids. you're pretty contagious in this phase. And so you have spirochetes in different parts, and depending on what your interaction is with people, you're more likely to transmit it, but you're especially going to have the chance to transmit it if you are having unprotected sex during those times. These are some pictures of various cutaneous manifestations in adult type syphilis, and you kind of see these classic kind of coppery circular lesions that happen on people's skin and includes the palms and soles. Over here on the right, you can just see it's just this kind of lumpy, bumpy rash like you can see, and it's hard to tell one versus the other. You can see that sometimes it has this little colorative scale on some of these lesions, especially on the soles of the feet. It can cause hair loss. It can cause, lesions on the tongue. And again, we have this classic kind of white topped discrete lesions, this condyloma lata. So all kinds of things can show up, and it's hard to tell, one versus the other about what's going on. After you pass through the secondary stage, you now go into the quiescent phase called the latent phase. And again, you may not have any symptoms, you usually don't, but you kind of wax and wane with things as things kind of reactivate from time to time. And we break the latent stage up into early latent, which is within that first year of infection, versus the late latent, which is beyond that first year of infection. And the reason why we do that is that the treatment is different. You give a single dose versus 3 doses of penicillin if you're in the early versus the late. If you don't get treated, then about a quarter of people develop tertiary syphilis. And this is where you can get some of these really dramatic manifestations of the disease that you've probably heard of and read about and potentially even seen over the years. If you take care of adults, we don't usually see it in kids because it tends to take decades to manifest. But the CNS is one of the areas that can be affected. You can get things like tabes dorsalis. You can see here on the right there an abnormal slice of spinal cord in a person who had tabes dorsalis. You can get neuropathies. You can get generalized paresis. You can get, go into this catatonic state. People describe, different bouts of insanity in people back in the 1600s that probably had syphilis. And so you can also get these soft tissue lesions that are these, they call them gummas, and they're granulomatous lesions that can invade the CNS and cause mass lesions as well. But as you can see here, they can invade other places as well. And so this poor gentleman has these really large gummatous lesions, but they also can cause erosive lesions that can be painful. You can see here that the soft and hard palate's been eroded, and also the cartilage has been eroded as well. So lots of different places that these can go and cause trouble. This poor gentleman has aortic aneurysm, so that's the other place that tends to cause problems years later. And you can see that his aneurysm has progressed so badly that it's eroded through his chest wall and is now this kind of soft tissue mass. This is a later case that is from a textbook as well. You can see this huge area. This is not the chamber of any chamber of the heart. That's actually the aortic aneurysm, and so again can cause major problems. When we talk about how to treat syphilis, we treat based off of the stage of infection. And so there's different regimens depending on where you are. And really, it's penicillin. Anything else is substandard and doesn't work as well. And the good news is that penicillin works very well. And you can kind of see here from the CDC graphic here that once penicillin comes along on the scene, all the stages of syphilis markedly decrease because it works so well. And people thought this is the end of the disease. But of course, as we're going to talk about more, we're seeing a whole lot more in a big resurgence for a lot of reasons. The thing that's important to know is that penicillin really is the best thing to use during pregnancy, has the best track record and the best chance for cure. And so if you've got a pregnant person who has anaphylaxis to penicillin, the recommendation is to desensitize that person and still treat with penicillin. And that's because the mortality is 40% in congenital infection. And so you really need to be aggressive with treating these people. You can get a Jarisch-Hersheimer reaction. It's as you are treating the infection, then you can have a reaction where you can have fevers and chills and sometimes hypotension and that sort of thing. And unfortunately, that can lead to preterm labor. But again, it's not a reason to withhold treatment because that high mortality rate if you don't treat. So again, it's based on the stage. So that infection within the first year, primary, secondary, early latent, usually we treat with a single dose of intramuscular benzathine penicillin, and that's usually good enough. but you're going to follow the patient and make sure that that's the case. If you're latent, again, you have infection beyond that first year, you get 3 doses of penicillin, IM, benzathine a week apart. And if you've missed that, especially during pregnancy, then you restart the series. If you have neurosyphilis, you do IV penicillin for 10 to 14 days. And in congenital infection, we'll talk about the various options as well, but it's similar versions of this. If there's a penicillin shortage, which we are having currently, especially with benzathine penicillin, there are some other things to consider. But again, ideally it's penicillin. And since the highest risk scenario is pregnancy, we try to make sure that we're saving the benzathine penicillin for pregnant people. So, or IV penicillin for pregnant people or neurosyphilis. If you're not pregnant, you can try doxycycline for about 14 days, and that seems to work. But again, you need to have close follow-up to make sure that they have responded. There's a question of, will ceftriaxone be as good as penicillin? We don't know. It seems to work okay in the anecdotal and some of the case reports. But again, it's really penicillin, if at all possible, for pregnancy and congenital infection. So the other thing is you're going to want to treat the sex partners, but it depends on, where the exposure happened as far as timing goes. So the incubation period for syphilis is about 90 days. And so if someone has been diagnosed with syphilis, you look back at who their sex partners were within the last 90 days, and you basically treat them. You're going to test them, but you're going to treat them no matter what their test result is. If you have somebody who had a sex partner that was more than 90 days from that time of diagnosis, then you can test them and then treat them if positive. But with the caveat of, if they're not going to show up for follow-up, you just treat them anyway. There is the chance of using things like post-exposure prophylaxis, and the CDC has now come out with new recommendations for consideration of post-exposure prophylaxis in exceptionally high-risk patients. And that's men who have sex with men and transgender women. If they have unprotected sex, you could give a dose of doxycycline. I believe it's within 72 hours, and that may prevent syphilis. And I forget if it's gonorrhea versus chlamydia they have data for, but it has potential activity versus all three of those. And so you can decrease the risk of getting infected with that. That's a shared decision-making decision with the person. And so you can talk to them about that. But they haven't gone any farther than saying we should be offering it to everybody else, because that's where the data is right now. I would not be surprised if down the line they get more data and suggest doing that for other people. So looking at, where syphilis is going, you can see here on the right that over these, the last couple of decades, syphilis is skyrocketing. And this is all ages, all races here in the United States. And this isn't happening because of antibiotic resistance. Penicillin still works really well. But remember, we're dealing with these other things that are giving us a higher rate of syphilis. Things like poverty, drug use, multiple sex partners, and multiple STIs. And so it's not surprising that, we're struggling with these things in the community, that we're having more and more syphilis here in the community, in Arizona and in the United States. And so when we look at what's going on with Arizona, and again, the rest of the US, blue is bad and dark blue is especially bad. And Arizona is number 5 to number 7 in the nation as far as rate of syphilis goes for adults, depending on which stage you're looking at. And again, not surprising that we see that in infants with congenital infection. So this is the map for congenital infection. It looks pretty much the same. And again, as you see syphilis rising in women of childbearing age, it's not surprising to see syphilis rising in their babies that they're delivering as well. And Arizona is also doing really poorly as far as congenital infection goes. And so we're number 3 in the nation for rate of congenital infection, behind South Dakota and New Mexico. And so if you look at here, we're up 450% over the last several years. And it basically has been increasing year after year. And you can see that in 2022, which is the latest data that the Arizona Department of Health Services has, there were 32 babies that died in that year because of congenital infection. And really all of this is preventable. And that's the really sad part for our state and for the rest of the country. When we look at, congenital infection and what the scenarios are with mothers, we can see, again, all the rates of infection are going up. And we can look specifically at what are these missed opportunities. So this is CDC data from a few years ago. But you can see this green bar here of infection that happened. There was no prenatal care. And so since they didn't get prenatal care, they didn't get tested. Here in the purple, you can see that they got a diagnosis, but they didn't get treated adequately or quickly enough. Here in the pink, they had late seroconversion during pregnancy. And here in the orange, you can see that they got prenatal care, but they didn't get tested. At the very bottom, the screen was they got tested, they got treated, there was still breakthrough disease. And so you can see that almost all of this is missed opportunity, that if we were to find pregnant people and screen them and treat them and screen them regularly, we should be able to treat disease and prevent this from happening and getting into the baby. And yes, there is some breakthrough disease, and we'll have to deal with that. And we do deal with that. And that'll kind of help make sense of this algorithm that we have in the Red Book and the CDC when we go through it here in a few minutes about working up babies and treating them. But again, the moral of this story is that we really have opportunity to diagnose and treat pregnant people and prevent the problems that we see with babies. So when we're looking at congenital infection, again, running through stats, I'm not a huge fan of stats, even though I put that one question at the beginning, but this really helps inform why we do what we do. So remember, 70% of women that delivered an infected baby only had one sex partner in the last 12 months. So really is telling us we need to screen everyone. It doesn't matter what their history was. The other thing is that half of people that delivered an infected baby had a negative screen. So like, remember that baby with that ulcerative lesion that I showed you? That mom was negative at the beginning of pregnancy. And so 50% of these babies that have infection are born to moms who had a negative test initially. So we need to be testing not just at the beginning of pregnancy. Remember that high transmission rate from mom to baby. And so that's why we were really aggressive with testing and treating babies after they're born if mom has had syphilis during pregnancy. And then again, that 40% mortality rate during pregnancy for infants and fetus. And then the other thing that's problematic is that 60% of babies who have infection are completely asymptomatic at delivery. So you can't look at a baby and say, no syphilis here. You can't look at the scenario and say, mom was in a monogamous relationship, no risk for syphilis here. And that's why we need to do this universal screening on moms and then testing babies if it makes sense. The other problem is like we saw with that baby who had that scalp lesion was totally normal at delivery. Almost all babies who have congenital infection will go on to develop clinical disease if you don't test and treat them. And so again, everything is really high and a lot of bad things can happen. So when we look at how, syphilis manifests in babies, we break it up into early versus late. Early tends to show up in the first couple of years of life. Late tends to show up beyond the first couple of years of life. And you can see abnormalities in the placenta. You can see abnormalities in the baby when baby is symptomatic. And it can, again, really go through all the organ systems and cause problems. And so it can be really dramatic with things like hydrops and IUGR. They may have hepatosplenomegaly. They may have other things that aren't noticeable unless you go looking, like cytopenias. They may have rashes at different times. And certainly it can infect the CNS. And I'll show you some pictures of different things that can happen here. They can definitely get a pneumonia. It tends to cause a whiteout where they call it a pneumonia alba, but it may not be as severe. And then this is a baby that Dr. Shehab had before I got here that he shared the pictures with. But this is a little baby that you can see these circular lesions on the skin, including the soles, and also wasn't using the arm and leg. And so had pseudoparalysis. And that was because that baby had syphilis and had osteitis that was causing pain. These are some stock AAP photos that also show more kind of what you can see on the x-rays. And so this is why we get x-rays on these babies when we suspect congenital infection. You can see the erosion of the bone here. You can see the periosteal lifting there. You can see cupping at the ends of the bones. You can get things like the snuffles. And so this is teeming with spirochetes, so you don't want to touch it. This tends to happen days after the baby was born to a couple of weeks after the baby was born. And it can be really inflammatory and erosive. And so you can get fissuring of the mucous membranes that's painful. And then, after all of that, you can get late manifestations. And so it can do things with the bone, the teeth, the skin, the joints, the eyes, all kinds of stuff. And so this is a gentleman who had the saddle nose because of the erosion of the cartilage. And he's got these fissures of the skin that they call raggeties. And he's got frontal bossing that you can't see here on the picture. You can have keratitis and blindness. You can get hearing loss. The classic other thing that you can see is Hutchinson teeth, and that is the notched incisors and other abnormal teeth findings. And this is the secondary teeth, right? So you're going to see this years later as the patient grows up. And you can have these lumpy, bumpy molars called mulberry molars. The osteitis can be chronic and cause Saber shins, and you can get painless swelling in the knees called Clutton joints. And so there's all kinds of things that can happen later on if you don't test and treat these babies. So what we want to do is obviously not have baby get syphilis in the first place, but when congenital syphilis is there, we want to find it quickly and treat it. And the algorithm is set up really to treat. If you look at the algorithm, I'll show you a picture of it here in a minute. It's kind of confusing. It's kind of complicated. It's definitely nuanced. But when you look at it, you'll recognize that it's really set up to treat in most situations, either because you're really sure it's there, you're pretty sure it's there, there's a high risk of it, or there's a little risk of it. And so most of those options are to treat in some form with a workup of some form. There is one option where you don't have to treat, and they've got these different, categories of confirmed, highly probable, possible, that sort of thing. So the higher risk, we just do 10 to 14 days of IV penicillin. The much lower risk and the really unlikely situation, you still usually give an IM dose of penicillin out the door and follow them up to make sure that you made the right decision. If there was no chance of syphilis at all, then you don't have to do workup. You don't have to treat the baby. So when we're looking at diagnosing people, this goes for babies and adults. If you've got a lesion, you can certainly look at the lesion, and you can do, like, especially with an adult that shows up with a chancre, you can do dark field microscopy, do a scraping and look at it and see those spirochetes. If you've got a biopsy specimen, you can do special staining to look for it. Those are unusual situations. That's not usually how we're looking for syphilis. So usually we're doing the whole alphabet soup of syphilis serology. And so you've probably come across some of these, and it can be quite confusing. And it wasn't until I started doing this here, where we had lots of syphilis over and over and over again, that it finally started making sense to me. But again, we've got all these different options that you can check for. And then it gets confusing too, because we look at things that are called treponemal versus non-treponemal. And we'll go through most of these things here in a minute. So the non-treponemal tests are your RPR and your VDRL. And what you're doing is they noticed early on in these patients, when they started looking for how can we diagnose syphilis, they saw that there was inflamed tissue in people, and that the body would make an antibody against that inflammation. And so you're basically, the non-treponemal tests are called non-treponemal because you're not actually measuring for the organism itself. You're measuring for this inflammation in quote unquote syphilitic tissue. And so this is an antibody against cardiolipin cholesterol lecithin, at least the RPR is, and the VDRL is similar. And so what you do is you set up the reaction, and you can see how it can react, antibody antigen. And you can see how there is a degree of interpretation here. And so you can get false positives and false negatives. And so it can be problematic. The nice thing is that these tests, the RPR and the VDRL, will reflex to a titer, and you can use that titer to help you sort out what's going on in the disease. Is it getting worse? Is it getting better? Depending on what you've done to the patient. And so when it comes to the RPR and the VDRL, any titer is positive. So it's not like a high titer is necessarily bad disease and a low titer is not so bad disease. Any titer is possible. And so if you've got a positive titer with an RPR or VDRL, and you've got a positive confirmatory test, then you've got infection. And then you decide what you're going to do with the patient based off of what the scenario is. When you're looking at your titers will change over time, whether you've treated or not treated. And what they do is they do dilutions, and the dilutions are doubling. And so a dilution of two separate dilutions, or fourfold rise or fourfold lowering, is clinically significant. A single dilution up and a single dilution down is probably not clinically significant. It's probably just lab variability. So you're going to look at that when you're trying to sort out what's going on with your patient. So for example, if you've got a patient who had 1 to 2 and they've been fully treated, and then oops, now it goes from 1 to 2 to 1 to 8, that's 2 dilutions. The 1 to 2 went to 1 to 4 and then went to 1 to 8. That's a fourfold increase. That's clinically significant. That patient's most likely been reinfected. And so you're going to want to treat that patient again. If you've treated your patient and your 1 to 16 drops down 2 dilutions, so the 1 to 16 goes to 1 to 8 goes to 1 to 4, you're fourfold, you're 2 dilutions down, you're on the right track. Your patient has been treated appropriately. You're going to confirm that that goes away and stays away. And so you have a response to therapy. We also look at, in congenital infection, we look at what mom's titer is and what baby's titer is. And again, that fourfold increase in baby over mom would indicate that we're not just measuring transplacental IgG, we are measuring baby's own antibody that baby's making because baby's infected. So if mom has a 1 to 8 and baby's two dilutions higher at 1 to 32, baby probably has an infection. The caveat to that is baby can be infected and not have a fourfold higher antibody. So again, that kind of also helps you understand why the algorithm is set up to treat so many patients, because sometimes all we have to really go on is that RPR. So again, as you treat, the RPR or the VDRL titer should go away, stay away, become non-reactive. But that can take a long time in certain people. So women tend to take about 2 years for that to go away and stay away. And in babies, it takes about 6 months. And so again, you'll see what's going on in the patient and you'll see what your numbers are, and you'll have to interpret the clinical situation. So the non-treponemals, the RPR and VDRL, they can cross-react with other situations. And pregnancy is one of those things that can cause a biological false positive. You tend to have low titers with that. So things like lupus, things like EBV, other things can cause the RPR to be elevated for a period of time. But you shouldn't be having a really high titer, but you can, just like, all the other caveats that can happen. When you're following your titer, you pick one test and you run with it. So you don't compare an RPR to a VDRL, you compare an RPR to an RPR. And that's because the scale is a little bit different. And then that way you have more accurate results. You can get a false positive because of what's called the prozone phenomenon. And basically what happens is there's so much syphilis in there that the antibody antigen reaction isn't working correctly with all the inflammation that's going on. And so what you can do is, if you're really worried that that's the case, you can ask the lab to dilute that specimen even more in order to get things where the antigen antibody lines up and you get your reaction. It's pretty rare that you need to do that, but I've asked them to do it a few times because I wasn't sure exactly what was going on and I wanted to make sure that that wasn't the case. So the treponemal tests are antibody-based tests that are looking at, reaction to the organism, the immune reaction to the organism itself, Treponema pallidum, subspecies pallidum. And so again, another set of alphabet soup things like the TPPA, which is the Treponema pallidum particle agglutination test, which there's a picture here, and then the EIA or the CIA IgM IgG. And those are the most common things that people use around here because they have the least user variability. But there's also FTA antibodies and microhemagglutinin tests and a few other ones out there as well. But again, the TPPA and the EIA or the CIA tend to be the most common one. These are the kind of tests, like a lot of other antibody tests, of once positive, always positive. And so they're not great for screening tests in general, although people have been using the EIA and the CIA because they're easily automatable and it doesn't require as much training and resources. And so again, we'll talk about kind of what the algorithm is here, but these are kind of the options that you look at. But again, these treponemal tests, the TPPA, the EIA, the syphilis antibody screen, they tend to stay positive for years and often a lifetime, but they can go away after a period of time sometimes in some people. So when we're testing for syphilis, it's a two-step process. You're going to get your screening test followed by your confirmatory test. And so the classic pathway that a lot of people were taught was the RPR or the VDRL, which is the non-treponemal, which again goes up and down with disease treatment. You get that, and if that's positive, now you get your TPPA to confirm, and you're going to get your titer with your RPR as well. The reverse pathway is using that once positive, always positive one, the IgM IgG. And if that's positive, then you add on your RPR. And if you have two tests, you're good to go. You've got syphilis and you decide what you do based off the clinical situation. If the RPR is negative, they'll often do a TPPA as well, just in case, because again, things like the prozone phenomenon and that sort of thing, but it depends on your lab and what your reflex algorithm is. So when we're looking at who needs to be tested, we basically, can look and see who's at risk. And so, pregnant people, obviously, we're going to test. And if you remember those stats, there's a lot of chance for syphilis in all stages of pregnancy. And so now the recommendations, especially in Arizona, are to test 3 times in pregnancy, at entry to care, at the 3rd trimester, and then at delivery as well. And then now, because we have so much syphilis around here, the CDC and the Arizona Department of Health Services is starting to suggest adding an opt-out testing if a person who has really high risk and is pregnant shows up to acute care, so urgent care ED. And so if you've got a person who abuses substances or has just been incarcerated, they highly recommend that you test these people. And I think this is a fantastic idea because most of the babies that I'm seeing that have congenital syphilis or have been exposed to syphilis during pregnancy that didn't get treated were this scenario where someone was using drugs, had poor prenatal care. And you look back on their history sometimes because they'll come to our institution and I'll see their ER visits. They have popped into the ER once or twice and they totally could have gotten a dose of penicillin that could have prevented infection in the baby, but they just didn't realize it and it was hard to do. So if you've got anybody who delivers a stillborn after 20 weeks gestation, they also should be tested for syphilis. And that's, like that first case that I showed. Obviously, if infants have any signs and symptoms of syphilis, we want to test the infants. And if mom isn't available to be tested because she delivered and left before you could do any testing, you can certainly do testing on the baby as well. And then if mom had syphilis during pregnancy, we're going to test the baby as part of our workup here, which I'll talk about here in a minute. So when we look at other folks, anybody who shows up with a sexually transmitted infection should also be tested for syphilis. And then if you've got an adult who participates in transactional sex work or has been incarcerated, again, a really high risk of this infection, so you should test them. And then other folks need to just be screened annually. And so since Arizona is such a high rate area, we recommend that anybody sexually active from the age 15 to 44 should be screened annually for syphilis. If you have really high risk, so MSM, who have multiple sex partners, who have STIs, that sort of thing, they recommend getting tested as often as every 3 to 6 months. And again, you're going to want to follow these people up and see, how things are and how they respond. So this is our algorithm that we use to try to sort out congenital infection. And it can be, again, confusing and nuanced. And then it's also annoying because you get to the end here and you now have to look up another step. But long story short is you look to see, did mom have syphilis during the pregnancy? And then how was she treated? And then what was her response? And then you look at the baby to see, well, does baby have any signs and symptoms? And then what's baby's RPR? And then you look at all of that and put it together and you decide, do we do a workup and IV penicillin? Do we do an RPR and an IM dose of penicillin, or do we do nothing? And so again, remembering that 60% of babies who have infection are asymptomatic and that there's a super high transmission rate if mom's infected during pregnancy, that adds into what we're doing for these babies and how we're interpreting things. So there are certain things that if you don't check the boxes for, you just get treated as far as the baby goes. The baby just gets a 10-day course of IV penicillin. You're going to do the workup, but no matter what your results are, you're still treating that baby with 10 days. And that's because of this high risk for transmission to baby. And so if baby has an exam consistent with congenital syphilis, doesn't matter what your workup is, you're getting 10 days of penicillin. If mom didn't get penicillin during pregnancy and she had syphilis during pregnancy, baby's just going to get those 10 days. If mom got penicillin, but you didn't start that treatment course before a month before delivery, again, high risk of breakthrough disease transmission, baby's still going to get that 10 days. And obviously, if mom has a relapse, so that RPR went up fourfold during pregnancy after treatment, then there's reinfection. You're back to that really high rate of transmission to baby during pregnancy. You're going to give the 10 days. And of course, if partner has syphilis during the pregnancy, then you're going to give that treatment as well. So again, that high risk situation, you do a full workup. But regardless of your results, you're getting that 10 to 14 days. And people usually settle out at 10 because I've not found anybody that says there's a specific situation where you need the 14 days. So in the workup of the baby in that high risk situation, you're going to get your RPR because remember, we want to compare it to mom's. You're going to get a CBC with diff because you could have cytopenias with congenital infection. You're going to get a lumbar puncture because you can see pleocytosis and elevated protein in congenital infection. And you're going to check a CSF VDRL. The interesting thing is there's not an RPR from the CSF. For some reason, it's just a VDRL. Whereas in the blood, you have an option of either one. You can do long bone x-rays to see if there's any osteitis. And I've had several babies over the years that have osteitis without the pain. So if it's that high risk situation, I just go ahead and do x-rays because they're pretty non-invasive. And then I tend to have the ophthalmologist look for any disease in the eyes because you can't really tell just by looking at them. And we fortunately have ophthalmologists that are easy to access. So that's on my list of things to do for these high risk scenarios. If you've got a baby who, no matter what the baby looks like, but the RPR in baby is fourfold higher than mom, you just assume this is congenital infection. So again, you would do the workup if you hadn't already done it, and you're going to give that 10 days of IV penicillin. Anything else, mom got treated appropriately, everything looks fine, baby looks fine, the RPR is not fourfold higher in baby than mom, you still usually give an IM dose of penicillin to baby just in case. There is an option to just watch and wait, but the problem is that follow-up is often not assured with these babies. And so I tend to be aggressive and give that IM dose, and that's the preferred regimen in the algorithm at this point in time because of those reasons. The exception to not giving an IM dose is if there was no syphilis during pregnancy. Mom had syphilis way before pregnancy. She got treated. She's over and done with. There's no signs and symptoms of anything and any risk, and her workup during pregnancy is totally fine. You don't have to give that IM dose to baby because there was no exposure. So then after we do all that, we need to make sure we follow up the baby. And so if the baby had an RPR that was positive, remember, we want to make sure that goes away by 6 months. And so we just check it at the 2, 4, and 6 month visit and make sure that that number is going down and then it goes away and stays away. If it's going up fourfold, that's clinically significant. Something happened. We're going to admit you, do the full workup, and treat you again. If it's still positive at 6 months, you're probably going to do the full workup, but it will kind of depend on the clinical scenario of what's going on. We used to do repeat lumbar punctures at 6 months if they had CNS disease, but the data shows that that's not necessary if your RPR is going down and going away at that point in time. If the baby had a negative RPR at delivery, but there was exposure during pregnancy, then we check it again at 3 months of age, and that's because that's the incubation period of the organism. So let's talk kind of RPRs and TPPAs and that sort of thing. And hopefully this will help kind of solidify what you do and don't do and that sort of thing. And again, I had to do this a bunch of times before it really became, straight in my brain of what to do with it, because it's really quite confusing. So you've got a mom that delivers her baby, her EIA is positive. So again, that's once positive, always positive treponemal test, right? So that was her screening test. And then the confirmatory RPR is 1 to 4. So you could have syphilis here, right? You've got 2 tests that are positive, but now you need to know what's been going on. If she's already been treated, that might be a good thing. If she's not, well, that changes the equation. So in her history, she's never been tested or treated for syphilis. So you got 2 positive tests, no treatment, you've got syphilis. So now you got to decide what the stage is. And, if you don't know when they got infected, you assume treatment worst case scenario, which is late latent, is 3 doses of IM benzathine penicillin a week apart. So that's what she does. So she gets that. She's going to get followed up on the back end. Hopefully all will go well there. But now we got to look at baby, right? So baby has a normal exam, great. The RPR is 4-fold higher than mom's. So we assume that baby has infection. Now we're going to do the full workup, right? And this baby's full workup is negative. But if you remember that algorithm, mom didn't check that box, right? She needed to be tested. She needed to be treated with penicillin before delivery, and more than a month before. You didn't do that. So no matter what this algorithm or what this, result is in baby, this baby's still getting 10 days. But we've got a positive RPR that's 4-fold higher. We're especially getting 10 days. So this baby has congenital infection. So he's getting the 10 days of penicillin. And now we're going to follow up that RPR at 2, 4, and 6 months of age to make sure it goes away and stays away. Look at scenario 2. Mom has an RPR that's positive with a titer of 1 to 64. And this is in early trimester, and she's got a TPPA that's positive. So she's got her RPR that's positive and reflex to a TPPA. She's got 2 tests that are positive. Again, let's see what her story is so we can sort out, where she is in her testing and treatment scenario. Well, she's had no prior testing or treatment. She's got disease. So there's a high risk of transmission to baby. We're going to treat her. Again, we don't know when she got infected, so we're going to assume it was late latent. She's going to get 3 doses a month or a week apart, and then she'll get followed up as time goes on. And so repeat it at 24 weeks, and now she's 1 to 16. So she's gone down 2 dilutions 4-fold, right? That's a good sign. We're on the right track. And then at delivery, you check again, and now it's dropped down another 2 dilutions. And so you're going in the right trajectory, and it really looks like mom has been treated appropriately, right? So now we need to look at baby and see what's going on with baby. So baby has a normal exam. And since the risk here is a lot lower, we don't have to do a big workup if the RPR in baby is okay. And so baby's RPR is 1 to 2. So mom's was 1 to 4, baby's is 1 to 2. Baby's is not 4-fold higher than mom's. We've got a normal exam. Everything looks like it's all well and good. Well, there's still a slight chance of syphilis. And so we still give an IM dose of penicillin just in case. And then we check at 2, 4, and 6 months since baby's RPR was abnormal. So another scenario, look at mom who shows up with who's delivered. She has an RPR of 1 to 32 and her TPPA is negative. So you only have one positive out of the two. And so you wonder, is this a false positive? Remember, you can have biological false positives. And so we asked mom, what her story is. Well, she's had prior RPRs that have been negative. She's asymptomatic. She's got no prior STIs and she's in a monogamous relationship. So you think maybe this is okay. There aren't a whole lot of risk factors. She's not using drugs. She got prenatal care, all that kind of stuff, right? Well, this is a really high titer. And this is actually an actual patient that we saw. And so there's literature out to suggest that the titers shouldn't be that high if you just have a biological false positive. And so we started asking more questions too, because, what else could be happening here? And it actually turned out that the father was not monogamous during the pregnancy. And so really made me worry that this mom could have infection. And so we added on an alternative test that we did the EIA, and that ended up being positive. So now you have 2 positive tests and mom had syphilis. And so we know that she seroconverted during pregnancy. And so we know that this is early disease. And so she only needed a single dose of penicillin. We worked up the baby and the baby's RPR was negative and the baby's exam was negative, but again, didn't check that box of getting penicillin during pregnancy. So this baby got a full workup and full treatment, just in case. And then followed up, since this RPR was negative, followed up that RPR at 3 months of age. Unfortunately, it was negative at that point in time. So back to our original questions, right? So the first one is the newborn in the newborn nursery whose term looks totally normal. The lab tells you that mom's got syphilis and has a rash that just happened a little while ago. So what are the chances of the baby having congenital syphilis at this point in time? What are the chances of transmission?
I'll let you know when I think you should go to the next one or
All right.
the result and then the next one. Although the 3 questions are posed at once, but I'll give time for people to answer the first one before you reveal the answer. And maybe just 1 more minute or less.
So far, so good.
All right, we're at 50%. So
All
we can
right.
go to the next one.
So
Yeah.
it looks like everybody got it. It's high, right? It's 60 to 100%. So again, it's just there's a lot of syphilis and a lot of risk. Question 2. So a pregnant person shows up and oops, has syphilis during pregnancy, but she's got anaphylaxis to penicillin. So are you going to defer treatment until after she delivers? Are you going to treat with doxycycline? Are you going to treat with ceftriaxone? Are you going to desensitize and treat with penicillin? Or are you going to treat with azithromycin?
I think you can reveal the result.
Okay. So remember, penicillin is what works. And so you really want to desensitize and treat with penicillin during pregnancy. And azithromycin really doesn't get into the fetus well. And so it's not recommended. There's really not an alternative treatment recommended during pregnancy, although some people talk that maybe ceftriaxone can work. If you ever get into the situation, you're going to want to call an ID doc and talk it through and see what your options are. But long story short, you're going to do the best you can with what you got, and then you're going to do the workup on baby and treat the baby on the back end. And what is the major driver of the congenital syphilis catastrophe in the US and Arizona? Is it A, inadequate screening recommendations, B, resistance to penicillin, C, inability to test quickly and treat pregnant persons, or D, reinfection after adequate treatment?
this point, I think pretty much most people who are gonna complete the quiz have done, oh, actually more answers are coming in. But yeah, I feel like we're at 84% of people completing the 3-question
All right.
quiz.
So this one again, it's inability to quickly test and treat. Remember that graph that I showed you with that bar graph that showed all those different colors. We've got all these opportunities to diagnose and treat pregnant people that we're missing. And obviously they're contributing to it too because they're not seeking prenatal care. But we really need to do a better job of getting people plugged into care and having that access so we can test and treat them. And so the recommendations are good. We're just not good at implementing them. We certainly don't have a resistance to penicillin. And sure, reinfection can play a part, but it's really we're not getting them treated in the first place. This is the major problem. So, take home points. We've got lots of syphilis everywhere. The transmission rates are really high from mom to baby, and the mortality rate is really high. And so we need to be really aggressive with screening and testing. And obviously, we need to be good at screening during pregnancy, remembering there's multiple time points where we can do that. And if they show up to urgent cares, ERs, when they have high risk situations. And then for sure, we need to be really aggressive with treating people. And again, penicillin is the drug of choice. So I think that's all we have for tonight as far as me talking, but happy to answer any questions.
I just want to thank you, Nate. That was great. Really enjoyed your overview there. Very clear. So we can open up for just a few minutes of questions. If you want to take yourself off mute or put it in the chat.
Right now, I'm also going to put the link to the survey in the chat for your use after this session ends, and I'll email it out as well right after.
So for those who are attending, if you want to receive CME credit, you have to complete the survey that is being put in the chat.
We have a question from Mariposa Wolford. How is the shortage being remedied?
Good question. I forget what they said the answers were. Part of it is I think they were trying to import some of the long-acting penicillin from Canada or Europe. I forget. The FDA had approved some use of that. I think the company that was making it was ramping up production again, but I don't think it's going to be I think it's going to be a while before they really are fully up and running with that. But I don't know more details beyond that.
Mr. Nagalingam, the shortage resolved for now. We have ample supply at El Rio, she says.
Yeah, and it seems like, again, if you really are prioritizing those highest risk people, so far it's worked pretty well. So, the pregnant people, the infants, that sort of thing. I've had, quite a few people that have come that I've talked to when I've talked to the mom. Mom got the penicillin, dad got the doxycycline. And so far it's been working pretty well. So the question is if a baby loses their IV in the hospital before the 10 days is completed, would IM penicillin be an option if IV access is not? So you can certainly do aqueous penicillin. It will kind of depend on what's going on. So ideally, you've done your full workup and gotten your CSF and your CSF VDRL, because benzathine penicillin is the long-acting penicillin. It doesn't have a high enough time above the MIC to adequately treat CNS disease. And so that's why they do IV aqueous penicillin, because that one does. And so you can certainly do IM aqueous penicillin, but the problem is you're doing that every 6 hours, and that's not, very doable in little infants. If you've done your workup and it really looks like that there's no CNS disease. I have done it to where you've done a few days of IV, the CSF looks pretty good, and you IM dose them to finish off the rest. And again, the key is the close follow-up, that you're making sure that the RPR is too negative at, going down and negative by 6 months. There's some data that if you can only get away with a single IM dose, they may turn out okay. But again, that assumes that there's not CNS disease, and there's not a lot of data out there. So one of my colleagues had a patient that just flat out refused everything, refused the LP, refused the IV penicillin, but said we'd be okay with an IM dose. And so with shared decision making, tried that and, ended up okay. So you do your best.
Any last question?
Nate, I have a question. Can you hear me?
Yep.
Nate, even if mom has pretty low titers, we can expect potentially placental transmission of antibodies, and as a consequence, we can expect positive RPRs in baby. If mom is continuing to check her RPRs, we're also checking baby. If like, I guess what I wanted to know is what induces sort of a transition from latent phase to back to a primary phase in those that maybe have had adequate treatment with penicillin. I just find it to be strange that all of a sudden we can have this sort of like reinfectivity phase later on, which could potentially happen both in mom and or baby.
Yeah,
You want to speak to that?
I don't know what kind of stimulates that change from kind of latent quiescent to active disease, to transmit. And I'm not really sure where the RPR figures in the untreated patients. So for example, I don't know that if you are untreated and your RPR is sitting around like 1 to 4 for a long old time, are you going to be having a higher RPR and be more contagious? I don't know that necessarily has been shown, but I don't know that data very well. But there are scenarios where what happens is you treat the mom and the RPR goes down, but it doesn't go away. It stays around like 1 to 1, 1 to 2.
Right.
And they call that serofast. And we think that is just a kind of persistent reaction of the test, but it doesn't necessarily mean that you have disease.
Right.
And so you have to be really careful with your history and what's been going on. Because there are people, they bounce around like 1 to 1, then it's 1 to 2, and then it's 1 to 1, then it's non-reactive, and then it's 1 to 1, and that's bouncing around. And the algorithm, it addresses that a little bit, but you really need to make sure that the treatment has happened. And if it hasn't, or if it looks like, now there's multiple new partners and they've had new STIs, usually you err on the side of caution and just retreat mom. And in those situations, I tend to err on the side of caution and, get the workup on baby and then decide where we go on that algorithm. And so it gets a little confusing, and it really depends on where you are and what your risk factors are. But yeah, it's problematic. But if you do see a 4-fold increase, probably what happened was they have real disease,
Sure.
and they probably got reinfected because their partner probably didn't get treated at the same time that they did, or they've got a new partner.
Well, thank you for speaking to that. I appreciate it.
Sure.
I have a couple more questions. I don't know if you're willing to stay on for a couple
Yeah,
more.
I'm
Okay.
happy to. We'll keep
So-
going until someone wants to stop asking questions.
Okay. Dr. Madden is asked, what is the process for desensitization of penicillin?
There's different ones. I've never done it. I've seen protocols, but since I've never done it, I forget. They tend to do it depends on where you are and what your scenario is. And people have been doing this more and more. And so people are getting a lot more relaxed with it. And again, it depends on who you talk to. But if you're being, extra cautious, they'll bring you into the ICU, they'll put an IV in you, they'll put you on the monitor, and they will give you small test doses of penicillin and make sure you don't react. And if you don't react, then they give you a higher dose. And if you don't react, great, here's your full dose. And now we watch you for a period of time. And then you just keep going with your treatment. But there are some people that, again, it depends on what your scenario is and what your history is. Like if you've had full-on anaphylaxis, they're going to be much more cautious. But if you've just had rash and that sort of thing, sometimes they'll do skin testing. And in that protocol, they may do skin prick testing too. But they may sometimes just give you, here's your dose of oral penicillin, how do you do? But if you've really had a true history of anaphylaxis, they tend to be much more cautious.
The next question is, how often do you check RPR level for patient with HX?
Sorry, with what?
With history of
Oh, yeah, history. Yeah. So again, it kind of depends on the scenario. So if you've been treated, I believe in adults, they recommend checking in another 6 months. In pregnant people, we do it a lot sooner because again, we're kind of seeing what's happening. And they're probably going to get stuck on that, timeline anyway of getting it in the 3rd trimester, then I get in delivery. But if you are, not in the pregnant stage, then usually you do it about 6 months later. And then you're going to test it annually in the higher risk patients that we mentioned, sexually active 15 to 44 of any sex, or sorry, any gender identity. And then the high risk people, you're going to do it much more often.
Those are all the questions that came in from the direct messages to me. I did also post the link to the survey. I didn't realize that I had sent it to just one person before. Do I have permission to email everyone your slides?
Yeah.
Okay, so I'll send that out. Probably, well, I thought I was gonna do it right after this, but I'll probably do it first thing in the morning if you all don't mind. And if there are no further questions, I suppose we've come to an end.
Yeah, we're good. Thanks, everyone.
Thank you.
Again, big
Thank
thanks
you.
to you, Nate, for the excellent presentation.
Yeah, great presentation. Thank you.
Thank
All
you.
right. Take care, everyone.
Bye,
Thank
everybody.
you so much.